All right. Hello and welcome everyone to today's webinar, Suicide Prevention State of the States. I know that we have still some folks who are jumping online, but we do have a tight agenda today. So we are going to go ahead and get started. My name is Charlie Severance. I am a policy specialist in NCSL's health program where I cover legislation related to suicide prevention. And I will be your moderator for the remainder of today's webinar. We are very excited today to have Dr. Deborah Stone with us. Dr. Stone is a lead behavioral scientist for CDC's suicide prevention team within the Division of Injury Prevention at CDC. And she's going to be providing a presentation today really in two parts, with the first part being sort of an update on suicide trends from 2018 to 2019, focusing on some encouraging news in terms of some decreases there. After that first part of Dr. Stone's presentation, we will have a quick Q&A session for any audience questions. You can ask a question at any time by using the chat function. You can do that by looking at the little chat box function, the little icon at either the bottom or top of your screen. And I'm going to go ahead and invite everyone to click on that chat box right now and just share with us where you're calling in from today or joining the webinar from today, the state that you're joining in from. After we've addressed those first few audience questions, we are going to get into the second part of Dr. Stone's presentation, which is really an overview of state work on suicide prevention, with the focus kind of on looking at the barriers, successes, and opportunities that states have to build on those successes we've seen from 2018 to 2019. At the end of today's webinar, we will have some time for me to provide just a quick overview of some of the legislation that we've been tracking in this area, and then address any final audience questions, provide some additional resources, and then we will let you go. Before we go to the meat of today's presentation, though, I do quickly want to thank the Centers for Disease Control and Prevention, especially the Division for Injury Prevention and Control, for their support, not just of today's webinar, but for NCSL's work on suicide prevention and other important injury prevention topics. But with that, I am going to go ahead and turn it over to Dr. Stone.
Thank you so much, Charlie, and good afternoon, everyone. My name is Deb Stone, and on behalf of my co-authors of this presentation, Andrea Carmichael and Dr. Melissa Brown, I'd like to thank you all for the opportunity to be here today to present to you. Next slide. I'd like to acknowledge the co-authors on the reports that I will be discussing today, shown here. Next slide. My talk today will provide background on suicide, a review of two recent reports, one highlighting changes in suicide rates between 2018 and 2019, and the second reviewing findings from CDC's State of the State, Territorial, and Tribal Suicide Prevention. I'll be happy to take some questions and answers at the end. Next slide. Before I begin, I always like to do a little bit of level setting with some basic facts about suicide. Next slide. So we are here today because suicide is such an important public health challenge that needs our continued attention. Between 1999 and 2019, suicide rates increased 33%. Suicide costs the nation $64 billion in combined lifetime medical and work loss costs each year. And when you add in suicide attempts and the costs associated with those, the figure goes up to about $70 billion. So in 2019, more than 47,500 lives were lost to suicide, or on average, 130 suicides or lives lost per day. Next slide. This slide shows the leading causes of death in the United States by age group in 2019. Here you can see that suicide was the second leading cause of death among people between the ages of 10 and 34. While suicide drops as a leading cause of death as people age, we do see the largest number of suicides in the middle years between 35 and 64. Next slide, please. As sad and tragic as every suicide is just the tip of the iceberg. many more people think about, plan, or attempt suicide, which puts them at increased risk for suicide in the future. In 2019, 12 million adults self-reported seriously thinking about suicide during the past year. 3.5 million made a plan for suicide, and 1.4 million attempted suicide. And among high school students, we found about 19% seriously considered suicide in 2019, and about 9% self-reported having attempted suicide. Next slide. In 2018, CDC released a vital signs report examining contributors to suicide in 27 states. We found that 54% of suicides did not have a known mental health problem, and instead many other factors shown here contributed to suicide. We now have more updated data from 40 states, and we still see the same pattern that about half of people did not have a known mental health problem when they died. This data suggests that in order to prevent suicide, we must consider all of these factors using what we call a comprehensive approach to suicide prevention that I will tell you a little bit more about later. Next slide. The next series of slides will describe changes in suicide rates in the US between 2018 and 2019, the year for which we have the most recent and complete data. Next slide. So early this year, we learned that suicide rates in 2019 declined for the first time in over a decade. The purpose of our analysis was to examine these declines. Specifically, we analyzed changes in suicide numbers and rates overall and by sex. We looked at rate changes by age group, by race, ethnicity, county, urbanization level, the mechanism or means of suicide, and by state. Next slide. We found that between 2018 and 2019, suicide rates declined by 2.1% overall. The decline occurred among both females and males by 3.2% and 1.8% respectively. Next slide. Suicide rates in 2019 were the highest among non-Hispanic American Indian Alaska Natives overall and among females and males in that population. Unfortunately, there were no rate decreases observed in this population. The greatest number of suicides in 2019 occurred among non-Hispanic whites overall and by sex, with more than 37,000 of the 47,500 suicides occurring within this group. Thanks. Suicide rates declined among whites by 2.2% overall, and among females by 3.8%, and among males by 1.7%. No other groups based on race or ethnicity, again, saw declines. Next slide. Turning to rates of suicide by age group, I'm going to be focusing here on the last column labeled decline. So as you can see, rates declined significantly overall among persons aged 15 to 24 by 3.4%, among people 55 to 64 by 4%, and among people 65 to 74 years old by about 5%. Significant declines also occurred among females 25 to 34 by 8.1% and females 55 to 64 by 6.3%. Among males, rates declined significantly in three age groups, 10 to 14, 45 to 64, and 65 to 74, with reductions ranging between 5 and 16%. Next slide, please. Next, looking at rates by county urbanization or population, we found that in 2019, overall and by sex, rates were the lowest in the largest metropolitan areas, shown in the darkest teal color on the left side of the bars, and increased as the level of urbanization decreased, so that rural areas, shown by the lightest colors on the right side of the bars, had the highest suicide rates. Where you see the asterisk, these are areas that saw significant declines in suicide rates from 2018 to 2019. Next slide. In 2019, as in most years, the largest proportion of suicides overall occurred by use of firearms, or about 50.4% of suicides. Whereas males were most likely to die from a firearm suicide at 55.6%, females were about equally likely to die from suicide by firearm, suffocation, or poisoning, with each comprising about 30% of the means used. The good news is that the rate of firearm suicide declined significantly from 2018 to 2019 by 2.9% overall, likely driven by a 2.4% decline among males. The rate of firearm suicide among females did not change. However, females did see a reduction of 10% in suffocation or hanging suicides. Next slide. So looking next at rates of suicide in states, we saw that the overall suicide rate shown on the left three columns declined significantly from 2018 to 2019 in 5 states: Idaho, Massachusetts, Indiana, North Carolina, and Virginia, with declines ranging from 8.6% in Virginia to 14.6% in Idaho. The suicide rate among females declined significantly in 3 states: Indiana, Missouri, and Washington, ranging from 17.3% decline in Washington to a 29.7% decline in Indiana. Among males, rates declined significantly in 5 states: Massachusetts, North Carolina, Florida, Kentucky, and West Virginia, ranging from a decline of 6.1% in Florida to 16.1% in West Virginia. Next slide. Unfortunately, 2 states saw overall suicide rate increases. These are Hawaii, where rates increased by 30%, and Nebraska, where rates increased by 20%. Among females, rates also increased by nearly 40% in Minnesota, and among males, rates increased by 35% in Hawaii and by nearly 40% in Wyoming. Next slide. The declines in suicide rates in 2019 are encouraging after 13 consecutive years of rate increases. However, few significant declines were observed by race, ethnicity, and most states did not experience significant changes, and a small number of states unfortunately experienced rate increases, underscoring persisting disparities in suicide in 2019. Please note that declines observed between 1 year and the next cannot be interpreted as a trend, and results should be taken with caution. A comprehensive approach to suicide prevention is urgently needed in all states to continue the initial progress made in 2019. A comprehensive approach can be characterized by at least 3 factors or features, including a reliance on the use of data for decision-making, involvement of multi-sectoral partnerships and collaborations, and implementation and evaluation of multiple prevention strategies with the best available evidence. These strategies should address the range of factors associated with suicide, especially among populations disproportionately affected. Next slide. In terms of what prevention strategies to implement and evaluate as part of this comprehensive approach, states and communities can use CDC's Preventing Suicide, a technical package of policy, programs, and practices for their selections. This slide shows a snapshot of the technical package and the range of prevention strategies with the best available evidence that can address the many factors that impact suicide. CDC is currently working with 8 states and 1 university to implement the comprehensive approach. This approach is important for all states, especially as we continue to respond to the COVID-19 pandemic and as we seek to reduce suicide rates across the country. Strategies from the technical package that may be particularly relevant at this time include strengthening economic supports, expanding access to and delivery of care, for example, through telehealth, promoting social connectedness, reducing access to lethal means among people at risk, teaching coping and problem-solving skills, identifying and supporting people at risk, and lessening harms and preventing future risks, such as through safe media reporting on suicide. And Charlie, if you can just click. These are the list of our inaugural recipients for our new 2020 Comprehensive Suicide Prevention Program. These are 8 states and 1 university who will be working with us for the next 5 years to help reduce suicide in populations disproportionately affected by suicide. Thank you. And so I will pause here as I believe we will take a few questions.
All right, thank you, Dr. Stone. We do have, I think, just one quick clarifying question from the chat. Would the poisoning category include intentionally using a lethal dose of prescription or other drugs?
Yes, so the poisoning category can include overdoses by prescription or illicit drugs and other substances.
Thank you for that clarification. And we did have another question. I'm curious, there was a concern that COVID-19 would increase suicide rates. Do you know if that's true? Obviously, these numbers are from 2018 to 2019, but that's been a big question, I think, on folks' minds.
Sure, and I can speak to that briefly. What we have seen, and of course, many of us who work in the field of suicide prevention have been very concerned that we would see increases in suicide on account of things such as social distancing measures and unemployment increases we've heard in substance use and violence and in other factors related to suicide that have been impacted by the pandemic. And what we know right now is that preliminary data from 2020 do show that suicides actually decreased by 5.6%. So we are encouraged by this, but we realize this is preliminary data and it's not data that has not been broken out yet by race, ethnicity, or age group. So we are waiting to see the full data. And we recognize that even though we see these preliminary decreases, we know people are really struggling, and that's been evident through different surveys and such that have shown increases in anxiety, depression, and so certainly we are tracking all of that data.
And then we had another question that came in through the question and answer function, and it's just, what does the data show for veterans? So I wonder if you can just quickly address any of the veteran-specific data that came out of this 2018-2019 report.
So unfortunately, our data do not address veterans, or so veterans are included in our data. However, our data are taken from the death certificate, and the death certificate does not include whether somebody was a veteran. So we're not able to speak to whether there were increases or decreases in veteran suicide based on this particular analysis.
Great, thank you for that clarification. And we can also follow up, I want to say, to any questions that we received that we don't have an immediate answer for after the webinar. Representative Orwell, I want to highlight that you asked a question about what are other states doing to prep for the 988 National Suicide Prevention Lifeline, which will begin in July of 2022. We'll get to that a little bit later in the presentation, so I do want to just address that quickly, but we will address that question, Representative. And I'm not seeing any other questions in the chat, but I do know that a number of our legislators are very interested in sort of the health disparities in this. And you highlighted on one of your slides sort of the disparities between urban and rural areas in terms of suicide rates. And I wonder if you could talk just a little bit about maybe what's causing those differences.
Sure. So we have seen this disparity between urban and rural counties for quite some time now. And we recognize that after the Great Recession, actually, the gap between urban and rural actually increased. And we aren't sure of all of the reasons for this disparity, but some of the things that may be happening are that we know, for example, and I mentioned the Great Recession, and now that was several years back, but we know, for example, that rural areas struggled significantly during the Great Recession, and to the point that some rural areas and groups have not bounced back the way other areas, for example, urban areas, have bounced back after the Great Recession. We also know that the opioid overdose epidemic has had really significant impact on rural communities, especially in the early part of the epidemic. So substance use is a pretty major factor for suicide. So there may be some contribution of the overdose epidemic to these increases. We also know that easy access to lethal means among people at risk is associated with increased rates of suicide. So for example, firearms or medications and other lethal means may be more prevalent in rural areas. And then there are a couple of other things that I could point to, potentially the availability of resources and helping services. We know that there are disparities in the number of, for example, mental health providers in rural areas. And also there's stigma around seeking help sometimes. So those are some of the things that I would point to that are potential factors for this disparity.
Great, thank you for that. I do want to acknowledge that there were a few folks that looked like who tried to raise their hands. If you do have a question, please go ahead and just put that into the chat box or the Q&A function, and we'll make sure to get that addressed. I did also want to highlight in the chat, it looks like a few folks aren't able to download the slides that were dropped in there. So I just want to reassure everyone that we will follow up by email with all of these slides, and they will also be posted on NCSL's website. But not seeing any other immediate questions coming through in the chat. Dr. Stone, I think we can turn it over to you for round two.
Great, thank you so much. So with all of that data in mind that I just presented, let's now look at what's happening in states, territories, and tribes. I'm going to provide you now with some findings from our recent report, the State of State Territorial and Tribal Suicide Prevention. Next slide. So just to give you a little bit of context here, between 1999 and now, there have been tremendous accomplishments in suicide prevention, from our first Surgeon General's report in 1999 calling for a public health approach to prevention to 2 national strategies for suicide prevention. The first one was published in 2001 and the second one in 2012. And we also saw the establishment of the National Suicide Prevention Lifeline, legislation for youth suicide prevention programming, to release of CDC's technical package and CDC's new funding for comprehensive suicide prevention. Despite these accomplishments and many more not shown, suicide rates, as I mentioned, have increased 33% since 1999, including a slight dip in 2019. To gain a better understanding of the current infrastructure and prevention landscape, as I like to call it, among states, territories, and select tribes, CDC carried out an environmental scan. Next slide. The environmental scan, there you go. The environmental scan was conducted in the summer of 2018 and had 6 objectives that essentially together, these objectives sought to gain a better understanding of the current infrastructure and prevention landscape among states, territories, and select tribes, or STTs, as I may refer to them. We wanted to identify gaps in resources and insights into why we may be seeing increases in suicide and to inform prevention going forward. Next slide. So the first part of the scan included a web-based survey and up to 3 representatives per jurisdiction representing all 50 states, the District of Columbia, the 5 permanently inhabited territories, and a selection of 15 tribes were invited via email to complete the online survey. Note that we actually got more tribes responding than we anticipated, so you will see in some of the results more than 15 referenced. The web-based survey consisted of 54 questions covering the 10 domains you see here. A total of 138 individuals responded to the survey. Of these, 87 were from states, 6 from territories, and 45 from tribes. The report provides a selection of state results from each survey domain with briefer results presented for territories and tribes due to the small number of respondents and in some cases, significant missing data. Next slide. So before I share the results here, I want to provide a little bit of context. According to our partners at the Suicide Prevention Resource Center, or Sbrc, and their infrastructure recommendations shown here, suicide prevention requires a designated lead agency to develop, carry out, and evaluate the state's suicide prevention plan. In addition, it advises that a strong foundation for suicide prevention should include leadership from a designated full-time person, and that person should have a core staff to carry out all of the necessary functions for suicide prevention work, including surveillance, program management, training, etc. So our results indicate infrastructure gaps. Specifically, only 32 states reported having a specific unit or office dedicated to suicide prevention. The number of staff ranged from 0 to 9, with an average of about 3 people. And nearly 1/4 of states had just 1 staff person dedicated to suicide prevention at the state level. Next. 2 of the 3 territories and 13 out of 19 tribes responding reported having a specific unit or office dedicated to suicide prevention. Next slide. The Sbrc infrastructure recommendations also recommend states should designate sufficient resources to carry out a comprehensive approach to suicide prevention. Such an approach would address the range of factors associated with suicide, use data for action, and include implementation and evaluation of evidence-based strategies. Our survey results found that annual budgets ranged from $0 or no dedicated funding in about 22% of states to between 1 million and more than 4.9 million in 7 states. When we looked at what states were spending their funding on, more than 80% of respondents said developing suicide prevention materials, training, and staffing. Next slide. 2 tribes out of 15 reported not having a suicide prevention budget. 5 tribes reported budgets in the lowest category above 0, from $1 to $100,000. And 2 tribes reported budgets in the highest category, 1 million to 2.9 million. On the right, you can see the breakdown for the 3 territorial budgets. Next slide. This next set of results examines states' progress towards the national strategy for suicide prevention. That national strategy lays out 13 goals. And what we found was that only 4 of the 13 goals were rated as having seen moderate or better progress towards their achievement. And the most progress was reported related to training community and clinical service providers on suicide prevention. Areas showing the most room for improvement include prevention research and evaluation of programs. Perhaps one of the most telling indicators of suicide prevention progress was the response to the following question. How likely is it that your state can reduce suicide rates 20% by 2025? And that goal is our national goal. And so what we found was that more than 50% of states responded that this would be very unlikely or somewhat unlikely to reduce rates 20% by 2025. And 11% responded that this would be somewhat likely. And most eye-opening was that no states responded that this was very likely at current resource levels. Next slide. So 2 territories and out of 3 responding reported that it was very unlikely they could reduce rates 20% by 2025. And 1 territory indicated that achieving this goal was very likely, actually. So we were happy to see that. The average likelihood rating reported from a total of 15 tribes was not sure or unlikely. Next slide. Survey respondents were also asked to describe their STP's capacity to implement a public health approach to suicide prevention, including routine surveillance and monitoring, data-driven strategic planning, implementation of evidence-based programs and practices, evaluation of programs and practices, and dissemination of what works or the best available evidence to stakeholders. And response options were provided on a 5-point scale from no capacity, 1 of no capacity, to 5 strong capacity. And so as you can see here, the average state capacity ratings range from 2.1 to 3.4, indicating modest capacity. Next slide. Tribes also rated their capacity for public health activities on average as modest, or a rating of 3.1, while territories rated their capacity a bit higher at 3.7 out of 5. Next slide. As I mentioned earlier, CDC released Preventing Suicide, a technical package of policies, programs, and practices in recent years. And this document laid out strategies and approaches with the best available evidence to reduce suicide. The strategies, again, are meant to address the contributors to suicide occurring at the individual, relationship, community, and societal levels. Overall, 82% of states said they were familiar with the technical package. States were asked whether they were currently implementing any of the 7 strategies. So as you can see here, most strategies were reported implemented by most respondents. The strategy implemented the least was strengthening economic supports, which aims to buffer the risk associated with economic and financial strain often associated with suicide. Next slide. Each technical package strategy was implemented by between 25 and 50% of territories, and we saw far fewer tribes reporting implementing the technical package. Most strategies were implemented by between 22 and 39% of tribes, except strengthening economic supports, which was implemented by just about 3% of tribes. Next slide. The survey also asked respondents about suicide prevention legislation or policies passed within the past 5 years. About 3/4 of states reported legislation related to K-12 suicide prevention in the past 5 years. Topics of other legislation are shown here in descending order, ranging from crisis support and mental health parity, legislation passed by 39% of states to workplace suicide prevention legislation passed by about 6% of states, shown at the bottom. And I'll give you just a moment to peruse the other topics of legislation and the percent that responded related to those topics. Okay, next slide, please. So the last two slides focus on barriers and facilitators of suicide prevention reported. Key barriers for states, territories, and tribes are shown here and include lack of sufficient funding in states, lack of adequate staffing, and lack of surveillance resources to monitor the problem reported by states and tribes, a lack of suicide prevention legislation and policies was reported in states and territories, and a lack of coordination and integration of services between partners reported in tribes. So those were some of the top barriers. And now I'll tell you about the facilitators. Next slide. So we saw facilitators including increased awareness of suicide as a public health problem and the National Strategy for Suicide Prevention. These were shared facilitators. States also noted other federal and national guidance materials and cross-sectoral partnerships as facilitators. Territories mentioned surveillance resources and strategic plans as facilitators, while tribes noted funding for suicide prevention as a key facilitator. Next slide. So our web-based survey was subject to at least two limitations. A small number of respondents per jurisdiction were included, and reliance of these respondents to speak to suicide prevention across whole states, territories, or tribes. So some of the information at the local level, for example, may have been obscured or not included here. However, our main group of respondents were suicide prevention coordinators who really are likely to have the best purview of activities in the jurisdictions. And in conclusion, this report presents an overview of the suicide prevention landscape across states, territories, and a selection of tribes or tribal organization, and depicts a diverse array of existing suicide prevention infrastructure, capacity, partnerships, prevention activities, and overall progress towards our national goal to reduce suicides 20% by 2025. It highlights gaps across all domains and suggests key areas for improvement, including the need for a comprehensive approach to suicide prevention, inclusive of strong infrastructure, multi-sectoral partnerships, and implementation and evaluation of prevention strategies with the best available evidence to address the range of factors associated with suicide. To turn the tide on the concerning trends in suicides in states, territories, and tribes, these jurisdictions can benefit from a determined national response, dedicated resources, and a resounding commitment from us all to save lives. Thank you very much. Next slide.
All right, thank you very much for that. I'll give everyone a moment to sort of think through the information that was just presented and see if you have any specific questions. Again, I do want to highlight in the Q&A that we have another remark about the 988 number, and we'll get to talk about that in just a minute. But we do have a few minutes here for Q&A if there's any burning questions that anyone has. I sort of wonder, Dr. Stone, if there's been any correlation that you've seen between states that have implemented more strategies from the technical package and lower rates of suicide.
I've wondered about that too, actually. We have not actually looked into that, but it's something of definite interest to us. And we have some additional analyses like that that we hope to be able to do in the future. And also, I'll note just again that our comprehensive suicide prevention program that I mentioned, which I mentioned just briefly, is requiring those funded recipients to select at least 3 strategies from the technical package, if not more. And so we'll be able to start seeing in several years how those selections have impacted on suicide and suicide attempts. So that's something that we really look forward to seeing.
Great. And you also mentioned as part of a comprehensive approach to suicide prevention, the need to leverage existing prevention resources. I think that was on one of your slides. Can you say a little bit more about what that might look like, or if there are any examples that you can think of, or maybe where states should focus their resources to fill the gaps?
Yeah, so in the comprehensive suicide prevention program, we are asking the recipients to do a scan of the existing prevention resources in their communities. And those resources can then be reviewed, and then they would select strategies to fill any gaps in the prevention that's going on in the community. And so we're looking at other prevention programs that might be impacting on suicide, other data that can be brought to bear, other partnerships or coalitions that we can bring to the table. So really harnessing all of the strengths that communities already have and hoping to have them bring those to their comprehensive approach. And then all of that can be evaluated and hopefully impact on suicide rates.
All right, thank you for that. And I'm not seeing any other questions coming through in the Q&A or into the chat. So I'm going to go ahead and launch a few polling questions so that we can sort of ask the audience a few questions and sort of get a pulse check for how folks are feeling. So my first question here is just, how do you feel about the information that's been presented here today? Were you surprised, maybe relieved to get a little bit of good news in this age of COVID-19? Did it confirm your expectations, basically what you've already sort of been seeing in your states, maybe some anxiety around the results? Give this a little bit more time to let some more folks answer it, and then we will share the results with folks. I'll give everyone 5 more seconds here to make a decision. All right. And hopefully everyone can see that. It looks like this more or less confirmed most people's expectations here. Few folks surprised, a few folks feeling relieved, a few folks feeling other, and maybe those folks who are feeling other want to share that in the chat, just what their thoughts are on this. I'll go ahead and launch our next polling question, if I can figure out how to do that. There we go. Sorry about that, everyone. Have you heard of the new 3-digit 988 suicide prevention lifeline? It's kind of been teased in the chat a little bit, so I think we can be a little bit quicker with this one. Give everyone 5 more seconds here. All right, so it looks like most folks have heard of this 3-digit 988 suicide prevention lifeline, and I'll be covering that in a little bit more detail in just a quick moment. And now I will launch our final polling question. And this is just, how familiar are you with your state's suicide prevention policies? Give everyone a few more seconds. All right. And it looks like most folks are at least somewhat familiar or very familiar. So we've got a lot of folks on the line who are very in depth with this information, but it looks like a few people who are sort of new to this issue as well. So hopefully for you new folks and for you folks who have sort of been at this for a while, this information has been helpful today. We do still have a few minutes left in our webinar for the day. So I do just want to quickly provide an overview of the suicide prevention legislation that we have been tracking here at NCSL. So far in 2021, at least 218 bills have been introduced on suicide prevention. 19 of these bills so far have been enacted and 182 are still pending. In total, 46 states have considered at least one bill related to suicide prevention. So if you're in the chat and you're looking at one of those states that did not, maybe you want to share if I got that wrong, but if you're one of the green states, maybe you want to share in the chat something that you've been working on or excited about in your state this year. Some common themes that we're hearing from legislators about these bills, many of them were postponed due to COVID-19 from the previous session. Obviously, many legislative sessions were interrupted in 2020 due to the pandemic, and a lot of important work got shelved and is now being taken care of this year. A lot of folks are interested in the impacts of COVID-19 on mental health and also the development of that 988 National Suicide Prevention Lifeline. In terms of the themes that this legislation was trying to address, by far the most prevalent was youth suicide prevention. And I think this echoes sort of the survey that Dr. Stone shared as well, where this has been a popular legislative trend for some time now. Suicide prevention training and crisis hotlines were also popular bills in 2021, though that figure does not actually include those bills related to 988 quite yet. Military and veterans, we got that question a little bit earlier. Obviously, legislators still very interested in supporting this community, but also in 2021, many bills responding to first responders and really those frontline healthcare workers who have been really taxed by the pandemic over the last year. So we keep talking about it. What is this National 988 Suicide Prevention Lifeline? The key details for states are really that it's a shorter 3-digit number that's intended to be easier for folks to remember. It builds off of the existing infrastructure of the National Suicide Prevention Lifeline, while still allowing for about a 2-year transition to allow for some network changes and to provide time to prepare for an increase in expected call volume. One of the key takeaways for states here is really that it does allow but not require states to impose a surcharge on certain telecommunication fees to support local call centers or to support sort of responses to 988 calls. So to answer this question of what are states doing in this field, in 2021, we've seen 17 states introduce 26 bills related to the implementation of the 988 National Suicide Prevention Lifeline. 4 of these states, Idaho, Kentucky, as was noted in the Q&A, Utah and Virginia have enacted legislation implementing some part of 988 in their states, with legislation currently pending or at least awaiting a governor's signature in 13 states. States have taken a number of different actions in this area, as we see in many different topic areas. Nebraska, for instance, has created a commission that will look at or study how best to implement the 988 number in their state. California's aptly numbered Assembly Bill 988 would create sort of mobile crisis units that would respond to some of these calls that come into the 988 call centers in California. And Utah has an enacted bill that has created a special fund that would support call centers in these states, in the state of Utah rather, and support responses to calls to the 988 number. I did quickly want to break down a little bit of what we're seeing around youth suicide, as that was sort of the biggest bucket of legislation that we saw this year. At least 78 bills introduced this year were related to youth suicide prevention, and at least 18 of these bills looked at suicide prevention training requirements for professionals who work directly with youth. So both Oklahoma and Hawaii there have examples of pending legislation that would make certain suicide prevention training requirements of teachers, for instance. At least 22 bills would expand access to crisis hotlines among youth, with many states interested in adding this information to student ID cards. The example that I have on the screen from Maryland would add the suicide prevention lifeline number to ID cards for students in higher education. And the example that I've shared from Indiana would do the same, but for students in grade school. I also wanted to cover the impact of COVID-19 on mental health and other related legislation and the ways that states have responded to mental health needs during the pandemic. The ways that we've seen states do this is really through supporting telehealth services for behavioral health, and also through allocating CARES Act funds and other federal funding directly to sort of behavioral health needs in respective states. New Jersey in 2020 had a bill, for instance, that would require insurance providers to provide the same level of coverage and reimbursement for telehealth behavioral health services as they would for in-person behavioral health services. Louisiana had a bill that expanded the kinds of providers that could provide telepsychiatric evaluations, and Colorado actually allocated some specific CARES Act funding to community behavioral health centers to cover unexpected costs related to the pandemic. In 2021, Georgia has a bill that would require the Department of Education in that state to develop guidelines around administering telemental health in schools. And California has a bill that would create a mental health resiliency program specifically for frontline workers. Again, that group that's been particularly taxed over the last year. And finally, I wanted to provide just a few more legislative examples. In Delaware, there's a bill this year that would that's currently still pending, but it would establish what is known as a gunshot project in that state, which is essentially a private public health partnership, wherein public health agencies partner with firearm retailers to provide information around suicide prevention to their clients. In Arkansas, there was a bill that's been enacted, and that bill would require that employees of suicide prevention call centers be trained specifically around veteran suicide prevention. Iowa has a bill that would sort of address the overlap between what we call adverse childhood experiences, which are sort of an upstream approach to preventing suicide. And Oregon has a bill that would create an adult suicide prevention coordinator within the Oregon Health Authority. So if you go back to really sort of those first few slides that Dr. Stone presented, you know, youth suicide is still, of course, a major problem, but so is suicide among adults. So that's one state that has taken a certain approach there. We will also be dropping into the chat, if we haven't already, a memo with additional examples from 2021, as well as a few of NCSL's resources, including our Reversing the Rising Tide of Suicide, which is our legislative report really broadly on how states have addressed suicide prevention. Our just published last week Preventing Military Veteran Suicides Legisbrief, which again looks at very specifically state legislation to address military veteran suicide prevention. And finally, our Behavioral Health and COVID-19 Policy Snapshot. And we do still have some time, so I'm happy, and it looks like there's a bunch of questions or activity in the chat to take some of your questions. Just give me a few minutes to sort of scan through here and see what's going on in the chat. Carmen Hansen from our team has provided some background on a funding opportunity that many states might be interested in. So take a look at that if you are interested in that federal funding opportunity. And it looks like most of the activity in the chat is just around different resources. Tennessee has a veteran hotline for suicide, and we have a few veteran coalitions to offer help in mental health services. Thanks, Sarah, for sharing that resource in the chat. And we have another question in the Q&A. How do you potentially see the Colorado National Collaborative impacting work across the nation? And Kim, I don't know if this is maybe a question for Dr. Stone or for me. I know that CDC has done a lot of work with the Colorado National Collaborative.
I can speak to that, Charlie. So yes, Colorado is one of the 8 states that we are funding currently for our comprehensive suicide prevention program. And we know that Colorado has been interested in working on this approach for several years and has really taken leadership in this area. And so we are really looking forward to our continued collaboration with Colorado and the other 7 states and one university, University of Pittsburgh, who are all now really implementing a comprehensive approach with similar ingredients to what Colorado is doing. So we hope that after this first round of comprehensive suicide prevention funding has ended, that we will see declines and that we can scale up this program to other states in the future.
Excellent, thank you for that. Another question that just came in through the Q&A: has the National Strategy for Suicide Prevention Goals and Objectives for Action been revised or updated since the 2012 report?
No, the strategy itself has not been updated since 2012. However, there was a 2021 Surgeon General report that just came out that called for the full implementation of the national strategy and all of the approaches in the national strategy. So there's still a focus on the 2012 with increased implementation needed.
Thank you for that, Dr. Stone. And it looks like we don't have any new questions in the chat, but there does seem to be a note that some of you might want to email some questions. So you do have my contact information. Tara Johnson from our team also shared her contact information in the chat, and you are welcome to follow up with some questions as you get the opportunity to sort of digest this information a little more fully. But at that, I will give it just a quick second here to see if there are any remaining questions that come through the chat. Thanks, Tara, for dropping our emails there. But otherwise, I want to thank Dr. Stone again for a fantastic presentation and for joining us today. And thank all of you for engaging with us in this webinar. We'll give you a few minutes back in your day and hope you have a great weekend. Thanks, everyone.